Can you please tell us your answers, like what you do in the case if you don't have a ABG machine? How do you manage the patients?
What you're going to do primarily for the patient? Is it taking time to type? Yeah. So like, yes, basic government set of managements, what we do is we check for SpO2 levels, we check for BP, we check for any signs of shock, how much is the distress. So routine investigations in severity kind of a patient, it takes time, I guess, Dr. Nurul, I guess. So what we do is we manage on the basis of an emergency kind of scenario. And I guess we refer the patient for the higher center, right? For the government setups, if I talk. So next comes is, so non-severe, as I told. How do you understand non-severe? It is symptomatic patients without any evidence of COVID-19, like pneumonia or hypoxia. So yes, someone said they have those ABG machines. How do you check hypoxia? Dr. Ketula Rajput. How do you identify hypoxia in the ABG? Yes, how do you identify? How do you know the patient is having a hypoxia?
So I request all the attendees that I'm repeating the question again. How do you identify the hypoxia patients on ABG?
See, SpO2 is fine. That is understandable. See, that's why I'm just focusing basically. I'm telling you, we'll be very basic. Everyone knows about COVID right now. No one needs any kind of a description. Every day we are hearing new kind of a variants. Every day it's coming. So just, yes. So O2 level is less than 80. Everyone is giving, yeah, it's fine. We won't go much in a detail kind of CO2 is increased. Very good. Yes. So basic knowledge, that is the most important thing that you need to know, okay, for anything that you do. So the moderate, fine, very nice. So for the moderate diseases, we see the patient with the clinical signs of pneumonia, that is basically fever, cough, dyspnea, fast breathing, but no signs of severe pneumonia, including SpO2. That can be more than 90 or equal to on room air. Okay. So I would like to know what do you understand with the dyspnea and orthopnea, the two, and apnea, three things. One is dyspnea, one is orthopnea, and one is apnea. What do you think? Dyspnea we know mainly we see in COVID cases. So how do you classify these three? Dyspnea, apnea, and orthopnea. Avoid using Google, I'll suggest. Just be very, I won't mind if you can, everyone, the one who can give a wrong answer, that's totally fine. You learn from that only. Dyspnea is fine. Yeah, I understood. I am just, how do you differentiate the dyspnea part, the orthopnea part, and the apnea part?
So for everyone, I'm just repeating the question. Can you please tell how do you differentiate between dyspnea, apnea, and orthopnea? Please write it down in the chat box.
Dyspnea, orthopnea, shortness of flying, apnea is.
So we have an answer from Samson. Orthopnea, shortness of breath on line. Apnea, respiratory arrest.
Yeah, very nice, very nice. Postural apnea is called orthopnea. Apnea is absence of breath. Very nice. Good. Good.
Thank you everyone for answering the questions.
So next, I would go to the low risk kind of what you saw, like everyone knows who was like people with low. Now, see, it's low risk people are those with a good immunity kind of a thing. But we have all seen COVID as like everyone has suffered COVID. Every person has suffered COVID. We know or we might not know. Everyone has suffered that. And low risk, basically, what we call people with good immunity, like children, young adults, become infected but are less likely to become seriously ill. Okay, but always remember they can also transmit the disease. Okay, and people at higher risk, severe risk include age with those underlying recommunicable, non-communicable diseases, uh, what we call people with comorbidities. Okay, so risk factors, we know, old age, more than 60 years, overweight, hypertension, cardiac arrest, chronic lung diseases, any cerebrovascular diseases, dementia, mental disorder, kidney, everything that you understand, like people are at with the higher risk factors. So what do you think all of these risk factors we can grade 1, 2, 3, 4 from 1, 2, 3, 4? How do you grade these all risk factors? Who are from top to bottom if we go? How do you grade all these things? Basis on your risk factor. If I say number one, what will be the number one cause, the number one risk factor for the patient if which can suffer? Yeah, chronic lung diseases. Because yes, very nice. Because patient is, it's the answer is in SARS only, the acute respiratory illness. Okay, so lung, it comes up first. Other comorbidities like immunosuppression, HIVs, hypertension, diabetes, these comes later on. Okay, in pregnancy, for the pregnancy, always remembers increasing maternal age, high BMI, non-white ethnicity, pre-existing comorbidities, and pregnant-specific conditions such as gestational diabetes and preeclampsia. So, how do you monitor? How do you monitor if the patient is at risk of the severe disease? If monitor oxygen saturation with pulse oximeter at least twice a day. You do you think like pulse oximetry is a very efficient thing? Yes or no? You think pulse oximetry decides it comes very accurate? It has a good specificity or sensitivity. Yeah, cardiac monitors. See, Dr. Noor, I understand, but I am talking on the both aspects. You said on for a good hospital you have a cardiac monitor. See, now after COVID-19, every government hospitals they are equipped with the cardiac monitors and ICU beds, but there is always a limited amount of thing that the hospital setups are given, like 3 to 4 beds only, and remaining are the ward beds. Okay, so mainly for by this we check for the patient through cardiac monitor. Yes, it is right, but in hospital setups we use obviously oximetry only. In oxygen saturation low, 90%, like less than 90%, we instruct like patient and caregiver to call the emergency immediately. If oxygen saturation is between 90 to 94, instruct the patient and caregiver to call the emergency help, as it ranges may be an early sign of deterioration. So I'll discuss here only. So like, how do you categorize? See, a person who is suffering of less than 90, it will needs to be taken to the hospital. Okay, 90 to 94 with symptoms of COVID-19. You suggest like there's not much of a severity. Do you suggest such patient to do a home isolation by taking hospital like a doctor's prescription or taking an advice from the doctor? You suggest the patient can be home isolated in such cases? Saturation of 90 to 94. And for how many days you need to ask the patient to watch for the symptoms? See, what is the main purpose for home isolation? Can anyone tell me? Why? Uh, yes, I understand. Very, very nice. A home isolation for 14 days. But why did government started home isolation? Why was it done? What is the main motto behind it? See, we are doctor fraternity. We need to understand all the aspects in this. Why did government started this part? Yeah, prevent spread is one thing. Okay, prevent family members from infecting. Yes, considerable. Any other? Yes. Yes, Dr. Punita, the main part, the main thing, yes, to avoid any kind of a load over our doctor fraternity, because you know how there was like the bed conditions, the shortage. See, people come to hospital. The main part of your field is the counseling part. How do you counsel a patient? They are some people are very much of like they are adamant in admission, like they want to get admit, they want to get admit, but it depends on you how to counsel in such kind of a patient. Okay, so basically it was done to decrease the load, to prevent the spread. And people, they prefer home isolations because they are in their places, so the psychological barrier the people have suffered due to that. Okay, and as you know, like, you people have must done online consultations for such kind of a patients. What kind of a oral corticosteroid did you advise to the patient? Everyone took those oxygen concentrators at their places. What oral corticosteroid? Dexamethasone, yes. Dosage? Oral. Injection, and dosage, and oral corticosteroid, prednisolone, yes. Dr. Ketula, nice. What was the dose? Hydrocortisone, okay. Injection. I'm not talking about oral corticosteroid. Yeah, methylprednisolone also good. Nice. Okay, that's nice. Good. So you know the basic thing like oral corticosteroid, methylprednisolone. We give in a hospital setup first primarily. So what do you think? Like if we give a patient who has come with a shortness of breath, BP of 150 by 100, and he's having tachypnea, and the BP is 150 by 110. Okay. And you give patient, is giving hydrocort to such patient beneficial? Yes or no? Shortness of breath, COVID, and BP of 150 by 110, pulse rate of 110. You think if we give the patient hydrocortisone, will it be beneficial for that patient? Why, Dr. Pranita? Why no?
Sorry, doctor, I just lost you in between.
Okay, no issues. Why, Dr. Pranita? Why we don't? Why it is not beneficial? It's okay, like giving is fine, like, but why it is not beneficial? Then what will you give to the patient to reduce the shortness of breath for the patient? Anyone? Yeah, like O2 therapy, we will start. Obviously, we need to maintain the saturation level for that patient. Okay. How about if I ask you people, how about we give a what we give a person furosemide, Lasix we give, right? Will it be beneficial if I give a patient Lasix? I give a patient 40 mg Lasix. Will it be beneficial? Yes. Now something be clicking in your mind. See, you know what is the average time hydrocortisone take to act? You know the time? Can anyone tell me? Diuretics, yes. Samson, yes. Tell me why? Yes, to reduce pulmonary. Will the shortness of breath come down? Okay, nice. I guess now it's clicking on your mind. See, hydrocortisone takes minimum of 1 hour to act. When we go give hydrocort, the primarily we ask we instruct the staff to give hydrocort, so that all the things that we are giving side to side, it will take minimum 30 to 35 minutes to you'll take minimum 30 to 35 minutes to manage a patient. So till then it start acting. See, hydrocortisone is not an emergency drug, always remember. Okay, we give Lasix. Okay, we reduce the what we call the shortness of breath for the patient. And every hospital, they have their protocols, their doctors have their protocols, they manage accordingly. I'm not saying that it's fixed for the thing, everything, to be very practical. If I say every hospital, they manage on their own what they think, but going in a right way uh, makes the patient more better. So we have given oxygen, we have given inhalational corticosteroids, we give Lasix, we give hydrocort. Anything else you need to give to a patient? You give injection dexamethasone. Okay. And if I say the RBS for the patient is 400, then will you give dexamethasone again? Why? What are you gonna give then? What are you gonna give? Will you give dexamethasone? If not, then what will you give? Yeah, that's very clear. We know that steroids increase our sugar level. So how do you manage that patient? How do you manage? Yeah, Pranita, very well. See, as I said, you need to give everything, you need to manage everything. Okay. That is emergency. You give essential drugs, you manage it accurately. There is This is how it goes. It is always in a series, A, B, C, D, E. Everything goes like that. We will give Dexa, we can manage it, yes. So it is not gonna it's gonna put a person like immortality or like that. You need to manage it well. So how, like, very nicely said, like you give insulin. Okay, we can. How do you give insulin like that? Do you give in a maintenance, or you give it directly? You give, you instruct, Hanji, give 15 like units, or give 20 units or 24 units. How do you do that? How do you give oxygen, sorry, uh, insulin to the patient of like that? You give it in a maintenance. Yeah, that is fine. The chart, basically, sliding scale. Okay, you give it like a set sliding, or if I say, if in dextrose, if I dissolve insulin like that, can I give that? Yes or no? If I mix insulin in a dextrose, Yeah, cool. See, we can give, if see maintenance, we can give in dextrose. If you suspect, see, as I told, see, it is on you. How do you manage a patient according to you? See, one today you are resident, tomorrow you will be a consultant. Okay. So you need to guide, you need to manage it well. Okay. Books won't go with you. Okay. The main is how do you skill it? How do you know it? You should know what the thing is, and you know the things only when you read, but don't imply it all the time, otherwise it will be a mess. And emergencies, you know, how do you manage it? You need to be very fast in that. Okay. Okay, good, good.